The toxicities of the two first-line regimens are important to consider and manage. With FOLFIRINOX, certainly there is the oxaliplatin-induced neuropathy, and then there is diarrhea, which can occur in up to 13% of patients at the grade 3, grade 4 level. So you need to manage that very carefully, really get the antidiarrheals on board, whether it is your Lamodals, your Imodiums, your short-acting triatide injections, making sure the patient is not pancreas insufficient, making sure that they have the appropriate pancreas enzyme replacement. And remember, these patients develop neutropenia, they're placed on antibiotics, their risk for Clostridia difficile, C. diff infections is also present. Some patients may have bile duct stents, which alters the amount of bile acids that are leaked into the intestines, which can also cause diarrhea. So all of these are considerations in managing diarrhea in pancreas cancer patients, especially with regimens such as FOLFIRINOX, but also Nal-IRI and 5-FU, which can also cause diarrhea. Neutropenia, I think we do a good job. That's what we do every day. You probably will implement growth factors. If the regimen is given every 2 weeks, you certainly can use Neulasta or Onpro. We do that in our practice. Neuropathy, the best approach is to back off, pull the drug out of the equation, whether it be oxaliplatin or nab-paclitaxel, and allow the neuropathy to recover. We will use gabapentin, pregabalin to try to reduce some of the symptoms associated with the neuropathy, but these unfortunately have not been as effective as we would want. With nab-paclitaxel, gemcitabine, the toxicities can include neutropenia, and that will affect your ability to administer the regimen on a weekly day 1, day 8, 15 schedule. So how can you counteract that? Well, one approach is to give the treatments every 2 weeks. With this, it's been shown that you can lower the neutropenia and associated toxicities, also the neuropathy, while maintaining outcome. Survival can be as high as 10 months. So that is one approach. Another approach is to do what we do with many regimens. Instead of going day 1, day 8, 15, we'll implement the break or the rest period after day 8. So a patient would be treated day 1, day 8 of a 21-day cycle. You still get 6 treatments in over an 8 to 9 week period. So those are the 2 ways that you can modify the gemcitabine nab-paclitaxel regimen in terms of schedule. There's obviously also opportunities to lower the dose. What I typically would do is, if it is thrombocytopenia, remember the gemcitabine causes that. It also causes neutropenia. So I might lower the dose of the gemcitabine from 1,000 to 800 while trying to maintain the 125 milligram per meter squared nab-paclitaxel dose. So those are some of the adjustments, certainly implementing growth factors, using appropriate antiemetic therapy are helpful in getting patients through the therapy. We also always have to remember we have to, in the very beginning, optimize the patient's performance status. We talked about nutrition, pain, intestinal biliary obstruction, risk of blood clot, psychology. All of those have to be managed not only in the beginning of our treatments, but as we go throughout the therapies. That's critical, and there's data to show that maintaining performance status will then allow the patient to receive the optimal benefit from our interventions, meaning they can survive longer with good supportive care. Supportive care in 2018 involves everyone. It involves a team effort. So what do I mean by that? It involves the chemotherapy nurses, the nurses that are on the telephone, the advanced practitioners, even the people checking the patient into the clinic have to pay attention to how the patient's performance status is going. For example, if the patient has a lot of diarrhea, nausea, vomiting, dehydration, on the first day of treatment, they walked in by themselves. On the 8th day of treatment, they're wheeled in by their family in a wheelchair. They've obviously had a significant compromise of their performance status. We need to really jump in and help with supportive care. Maybe think about giving intravenous fluids, and allowing the patient to continue with treatments that clearly have a benefit in terms of outcome.